Hello and welcome back after a week off, and a week and an hour off actually. We are back for another episode of Belly to Baby, and today we're transitioning a little bit. We've been talking a lot about pregnancy and mom and everything that goes into the first trimester and a half really of pregnancy, and now we're talking a little bit more about the baby and what's going on with this little creature that's developing. We did the 20-week ultrasound a couple weeks ago, and I can't think of any two better people to have with us to talk about what is going on inside than Dr. Barb Warner with our Fetal Care Center and Dr. Caroline Lee, who is a cardiologist with the Fetal Heart Center here at St. Louis Children's Hospital. So thank you guys both. That's, I know, a lot of introductions.
We love babies.
Yes.
It's a pleasure.
And so you guys, your job is to, well, we've talked to a bunch of OBs in the past. Your job is to take care of babies. So Barb, I'll start with you because you're with the Fetal Care Center more generally. Tell me a little bit about what you do and what you see and how you become involved in the care of a pregnant mom.
So most of the babies and mothers that we see prenatally have some kind of problem that very often was unanticipated. So our goal is really to work as a team. As a neonatologist, I'm involved and really focused on what the baby's needs are going to be. But I work very closely with my MFM colleagues and also with the other pediatric subspecialists. And so our goal is really to integrate in a holistic way the treatment of the mother and the baby.
So a couple of weeks ago, just to kind of bring everything full circle, we had Dr. George McCombs, who was my fetal medicine, if I can crank that out correctly, talking about the 20-week ultrasound. And he was saying that a lot of times with that 20-week ultrasound, you discover a lot of things that just need a closer look. And that is when the Fetal Care Center becomes involved. And when someone from, say, the adult side at Barnes Jewish would call someone from the children's side, and you'd start that conversation. And another one of those people, Caroline, you or Dr. Lee, you are one of those folks that gets into the conversation, specifically when we're talking about a baby's heart.
Yes.
So tell us a little bit about what you do and how you become involved in mom's care and baby's care.
So I'm part of the Fetal Heart Center, which is both part of the Fetal Care Center. As Barb says, the Fetal Care Center takes care of mothers and babies with any type of fetal anomaly, including the heart, or fetal abnormality, including the heart. So, but we're also part of the Heart Center, the Pediatric Heart Center at St. Louis Children's Hospital and Washington University. So we overlap both. So we at the Fetal Heart Center get patients referred for a fetal echocardiogram, which is a specific ultrasound looking just at the baby's heart. Really a detailed look at the anatomy, the function, the rhythm, the heart rate, in the context of the medical situation of the baby or the mother. So for example, we usually get kind of two main categories of referrals for fetal echocardiogram. They're what we call screening echocardiograms. Those are that nothing necessarily is suspected wrong with the baby or abnormal, but because the mother had a previous child with a heart defect, or the mother or the father themselves had a heart defect, if mom has diabetes before she was pregnant, if mom has some kind of other illnesses or diseases like lupus, those are some reasons why mothers would get referred, because for a fetal echocardiogram, a closer look at the heart. And then the other category of referrals we get, really an important one, is where at the 20-week ultrasound, when they're looking head to toe at the baby, they have a suspicion that there may be a heart defect, a heart abnormality, an abnormal valve or an abnormal blood vessel, or the heart's too big or too small, or the heart rate's too fast or too slow or irregular. So different concerns about the heart, they would come to get a closer look at the heart for those reasons as well.
Okay, so you see people for a wide variety of reasons, and I always like to bring up, I believe it was one of your colleagues who said at one point, it was Dr. Bevington, who is one of the fetal surgeons, who said, I hate that people always think we're here to give bad news. I give a lot of great news too. And
yes.
So I think that's important to point out, that not every circumstance that brings people here, they're very stressful oftentimes,
Yes. Mm-hmm.
but the end result is not always so bad.
That is true.
Are a lot of things that you can discover that are very positive.
Right. Most of the time we're able to give good news that the heart is normal, especially in the screening echocardiograms.
Terrific. And we're going to take a look in just a little bit at what goes into a fetal echocardiogram. And so stick around for a few more minutes if you want to see what a baby's heart looks like up close. I will give you a hint. It's black, white, and kind of blurry, but it seems that they can read these pictures very, very well. But we'll take a look at that in a little bit. But first of all, I just would point out, I don't think I ever remember to say my name at the start of this. I am Abby. I am 22 weeks pregnant, 22 and 2 days, I believe is what the math said whenever we were punching in the due date. So I'm right about the point that you would see a patient maybe a little bit later than you would see a patient whenever they're referred after that 20-week ultrasound.
Yeah, and anywhere between, sometimes that 20-week ultrasound happens a week or two before, so 18, but usually 18 to 22 weeks is the time that we get most of our referrals.
Okay, so I'm in a really fortunate position. Obviously, I'm here on the Washington University Medical School campus with all of these experts, and whether they like it or not, I have a full listing of their phone numbers, and anytime I need to, I just press the panic button and they answer my questions. But the good news is, because they are being so kind to give of their time here, they don't answer just my questions, they can answer yours too. So if you are watching and have a question, please feel free to punch it into the comments on this broadcast, and we will get to them as soon as we're able, and we'll answer those in real time. And if there are any questions that we can't answer in real time, we'll lead you to the resources where you can find better information. And here on this campus we have a lot of it. We've got the Women and Infant Center, which is joining the maternal fetal medicine and OB programs at Barnes Jewish Hospital and Washington University with the programs at St. Louis Children's Hospital, Washington University. So all kinds of information to share, and we'll try and get as much of it out of the two of you as we possibly can, but we'll go back a little ways to start. I know that it's so crazy because really that first appointment, the first thing you hear, and the thing that I know I was panicked about not hearing, was the heartbeat. So that was what, 6 weeks in, I think, 8 weeks maybe at that appointment. How early can you detect a heartbeat?
And that's about, it can range anywhere from that. Wouldn't be alarmed if it wasn't, you couldn't hear it that early, but that's generally the time frame that the fetal heartbeat can be assessed by ultrasound. The heart is one of the first organs to form, and usually even before a mom knows she's pregnant, the heart's been beating and forming.
It's so crazy to think about. It really is pretty wild. And then between that first 8-week appointment, or whenever that happens, in the very first appointment, until the 20-week ultrasound, Barb, there are a lot of different options and tests, and we've talked a lot about the variation of opportunities that people have to learn more information about the baby. Can you talk a little bit about some of those tests and what would bring maybe women to your door a little bit sooner than others?
So in the very early part of the pregnancy, there's a whole series of blood tests that are done as part of your obstetrical appointment. And those are screening blood tests. So those aren't definitive blood tests that will give you a very specific answer if there's a problem, but they're a screening test to see, is this baby at higher risk for having typically underlying genetic defects or underlying structural defects. And then based on the results of those tests, you'll go on and do a higher level of testing. Now, one of the areas that's really exploding right now is the area of genetics, and being able to identify some genetic abnormalities very early on. So who would be someone that would be identified as a good candidate for that kind of testing? So typically mothers that have higher, that are older, I don't think of them as older, but they're typically above the age of 30 or 35. The risks for genetic abnormalities increase. And one of the tests that's now becoming increasingly common is looking for the fetal DNA within the mother's blood.
Is that the one that tells you the gender at about a minute and a half pregnant?
So you can identify the baby's gender.
And so much more. I know everybody focuses on the gender.
Yes, it is, and it is always exciting to get that information. Some parents don't want that information, so they may be getting the test for another reason, but they don't necessarily want that information, but you can get that information definitely from that. And the other category of women that would be qualified for those type of tests would be if there were some abnormalities identified either at the 20-week ultrasound or potentially even earlier. And so that testing, it typically had been that the first line of testing, if there was some concern, would be an amniocentesis, where a needle is placed into the amniotic fluid through the maternal abdomen, and a sample of that fluid, which contains fetal cells, is removed. But now the first line of testing is going to the mother's blood and trying to detect fetal cells within the mother's blood. It's important to realize, and I think this is the distinction that sometimes gets lost, is that is a screening test for some very specific abnormalities. And if there's concern about either anatomic abnormalities like a heart problem or other abnormalities that are seen, then a more detailed genetic test, which is an amniocentesis, would be recommended.
Okay, so that's actually a really important distinction, because my next question was going to be, so I remember the amnios, I remember when I was babysitting, actually, the mom of the kids I was taking care of was pregnant with her third child, and she was over the age of 35 at the time, and that was it was no reason other than that, but she wound up with an amniocentesis.
Yes.
But now there would be a blood test typically preceding that.
Yes, you can typically do this blood test as a screening test. Now again, it doesn't test for all genetic abnormalities, so depending on what the findings are in the baby, even that blood test may not be applicable to what they are specifically looking for. So it's a screening test for some very specific genetic abnormalities. The amniocentesis is still the gold standard and provides much more information. And the blood test in the mother may or may not be applicable to the particular situation that a mother and fetus has.
And so do you wind up seeing patients that early? I mean, it's far, I think it was the 12-week mark?
We typically don't see them as early as 12 weeks. Typically, most of the time, because the diagnosis is made around that 20-week ultrasound, it's around that 20-week ultrasound. But we have seen patients very early as parents kind of go through the journey of what they're going to do. You know, one of the questions is why do that? Why try to find out more information prenatally? And some parents would say, well, it's just going to make me nervous. It's going to make me enjoy my pregnancy less. But the importance is that it can make a difference in what happens in the delivery room and how that baby is treated in the delivery room. And that can make a difference in how the baby does long term. So we can set up plans ahead of time. If there is a problem and we know what that problem is, we can ensure that the correct people are present in the delivery room that need to be there. The correct specialists are aware of the problem ahead of time, and the parents can plan what are things going to be like over the first weeks of life. What can I expect? What kind of child care issues am I going to have to put into place for my other children? So it's both to help plan for the care of the baby as well as for the parents to help plan their own lives.
And Caroline, you and I were talking about this a little bit earlier too, about how important it is to take into consideration the fact that mom's a patient too, and once that baby is born, a lot of times, especially with issues that you see, the diagnosis comes after delivery, and when that happens, mom and baby are separated. Can you talk a little bit about the benefits of knowing information earlier for that?
Yes. So congenital heart defects, so abnormalities of the structure of the heart, are the most common birth defect, and so occurring in just under 1% of all pregnancies. And it's been reported that still, at least in our area and in our hospital, less than 50%, less than half of babies with really significant heart defects get diagnosed before birth. So over half come in, are diagnosed after birth. And in that case, if the mom is from out of town or has delivered even locally here in St. Louis at a different hospital, if the diagnosis of a heart defect is made, it can often mean that after birth, it can often mean the baby has to be transferred to a pediatric heart center such as ours for further care, and their separation of mother and baby. And then, of course, in addition to that, there's the shock of processing what the baby's heart diagnosis is and the type of intervention they may need. So we are really working hard to improve the prenatal detection of heart defects, trying to help hone some skills and on the 20-week ultrasound on how better to look at the heart to increase the chances of detection. So, I think moms want to be near their babies, whether it's a normal baby delivery, of course, or in this case, for us, if there is a heart defect, if we know ahead of time, then we can plan, along with our colleagues in the Fetal Care Center, neonatologists, the maternal fetal medicine doctors, for delivery here at our medical campus, where they can be delivered at Barnes Jewish Hospital, and just next door is Children's Hospital, and it's all connected. And the baby and mom as soon as she recovers from delivery, can be taken to be with her baby. And so instead of having a transfer where the mother and baby are separated. And so that's, I think, one important reason for a prenatal diagnosis. And also, as Barb mentioned, how to care for the baby in the delivery room. How the neonatologists approach a baby with a heart defect, depending on what it is, may be different than a normal baby that they would be attending to. So having that knowledge for the team at the delivery room. And then, we have a cardiac ICU here at Children's Hospital too, and so delivery at the adult hospital and transfer over to Children's into one of our ICUs, the newborn ICU or the cardiac ICU, to further manage care and hopefully minimize. It's already going to be a stressful situation for any family who has a diagnosis of a baby with a heart defect, but to at least be in proximity can help.
And that's one of those things that we tell people, that's the beauty of, and we're obviously on a medical campus right now, as those sirens go by, you've also probably noticed a lot of construction on Kings Highway, and that's not only will the traffic ease up here in a couple of months, but there is a bridge, if you look toward the medical center, a new bridge that connects two buildings, and that is the bridge that's truly going to connect mom and baby. They're right there next to each other.
Right, that was one of the things where it said beginning in August, it'll really just be a hallway away. The other thing we really would like to do and try very hard to do is sometimes in the babies that have cardiac defects, one of the few times mothers get to hold their babies is right after delivery, because once they go over to the CICU and they need intervention, it may be a long time before the moms can hold their babies again. So we try very hard with our cardiology colleagues to make sure that initial bonding time between mother and baby takes place as lovely as we can make it.
And so you are both, you're the baby doctors, but so you're not taking care, you're working with the pregnant moms, obviously. Are you often in delivery rooms?
I'm in the delivery room all the time.
And why is that?
So my expertise is in taking care of babies that have problems, either known problems or unexpected problems. And so we have someone who is available 24 hours a day, who has that expertise. Very often the babies need additional help either with breathing or additional help from a cardiac standpoint in the delivery room, and that's what our job is.
Okay. And there's a whole team of physicians, and it was the funniest thing to me. I never realized until I started working here that these newborn medicine doctors are oftentimes in delivery rooms to make sure that everything's...
There's a whole pediatric team that's present in the delivery room. There's a team of both nursing staff that are specialized in care of the newborn and delivery room care, as well as physicians.
And it's so crazy with what you do. Someone had pointed out to me, and it's a very obvious point, but it's still kind of mind-boggling a little bit, is that obviously you go into the room with one patient, in theory, one person, but then before everybody is out, you have two, or in some cases, more patients with the multiples. So I'm not talking about dad collapsing on the floor, though I'm sure that happens too. But it is so funny, that number of people I've seen in delivery rooms here is kind of astonishing, and to know that many people are there to focus and make sure that everybody has a good outcome.
Yeah, and we do really want to make it a family-centered affair also. So it's important that the father participates, the significant other participates, and that other family members can be there, maybe not right in the delivery room, but available to support the family as well.
I've seen babies walk down the hall
Yes.
in incubators with
Yes.
with it looks like soldiers lining the halls.
We got to
and
stop and
families.
make sure grandma sees the baby too.
Yes. So that 20-week ultrasound, we'll talk a little bit about that, and then we'll go into a closer look at what you would see in an echocardiogram. I'm still learning the language myself. But what in that 20-week ultrasound would guide a patient into your care?
So from my standpoint, it can be an abnormality in really any system. Whether it's with the heart, in which case we work closely with cardiology. There can be neurologic issues with the brain, with the spinal cord. There can be abnormalities in the GI tract, in the lungs. So, many of these things, we always have such a biased view. Most pregnancies are normal. I just have to remind myself that most pregnancies are normal, but really any system in the body will bring a baby into fetal care.
And it's amazing the amount of technology we have now in all of this testing. I'm sure you do see a lot of people for, I'm going to say this incorrectly, I'm sure, but those screening issues that you then take a closer look, and we have the technology to look more closely, and then say, you're normal, out the door you go.
Mm-hmm.
Yeah.
Yep, that happens. Mm-hmm.
Okay, and we talked a little bit about the two different sets of parents that you see.
Yeah.
Is there anything in that, and again, a closer look in just a second, but is there anything in that 20-week ultrasound that that a doctor would be, a fellow physician would be on the phone with you saying, I need you to take a closer look at this patient?
Yeah, the most, at the 20-week ultrasound, the standard evaluation of the fetal heart includes making sure there are 4 heart chambers. And making sure that there are 2 outflow tracts, so 2 blood vessels that leave the heart normally. So if the sonographer, the person doing the ultrasound, sees an abnormality in the 4 chambers or those outflow tracts, that would prompt a referral. Again, if the heart's beating too fast, or the heart's beating too slow, or the heartbeat is irregular, those are other reasons. And then, as Barb mentioned, the other system abnormalities, such that if there was a GI tract abnormality, such as an omphalocele, where the abdominal contents are outside of the baby's body, that can be associated with heart defects. So if
Which can also be fixed. I mean, it sounds crazy, but it's something we've seen many times here, and babies do very well with it. It sounds very sci-fi to me, but...
And I think that is one of the messages that we want to give families also, is that even if there's abnormalities, there is a lot of technology that we can apply to improve how babies do in the long term.
Absolutely, right. So something like that kind of abnormality may be associated with a heart defect. So at the 20-week ultrasound, even if the heart didn't look necessarily worrisome because another abnormality was found, those often get a closer look at the heart as well.
Okay. And then is there anything that you can do between finding out and the delivery other than make plans and sort of coordinate care, or is it more just wait, monitor, and see?
On the heart side, a lot of what we do prenatally is to, because with critical heart defects, or those that will need surgery or cardiac cath intervention as a newborn baby or early in infancy, our time prenatally is spent counseling the family about the diagnosis and what to expect, and working with our colleagues to say, does this need to change our delivery plans? This family from Springfield, Missouri, do they need to come to St. Louis to have a safer delivery and transition into our cardiac ICU? So that's part of it, is the planning, so the mother and baby can be together at delivery, so the baby can be managed appropriately for the heart defect, and to let the family know what to expect afterwards. There are a few rare diagnoses, congenital heart diagnoses, for which fetal intervention is considered. Again, those are really in the minority, and very few centers do fetal heart interventions with varying outcomes. So for the most part, it's mostly about counseling the families over the course of it, and offering them encouragement and hope, because at the first visit often it can be overwhelming to understand. You just hear the word heart defect and you don't remember anything else that I will tell you, which we assume, and so having families come back for follow-up visits hopefully helps them process all of it. And we would really, I think, as Barb mentioned, want to support the family as well, that knowing that that's, of course, we're focused on the baby and the outcome, but supporting the mother and the father through it, and offering them hope and encouragement as appropriate is an important part of it too.
It is interesting because the area of fetal interventions, when the field first started, it was all about fetal surgery. And the big news was always open fetal surgery, where they would open the uterus and take the baby out for some specific defects. And now the focus is becoming increasingly on endoscopic interventions, so that instead of having to do a big cut through the uterus, some of the interventions are being done with an endoscopic technique.
And what does that mean
and
exactly?
That means people may have heard of it more from like having a knee done, where it's done endoscopically, where they put a catheter. You know, it's bigger than a straw, but it's about the size of a big straw maybe, and then they're able to look at the fetal surfaces and look at the fetus and do either a laser intervention. For the most common intervention is a twin-twin transfusion syndrome, if you have identical twins, and there's a problem with how the placenta is sharing their blood. We can laser some of the surface vessels. I can't laser them, that's Dr. Bevington, our fetal interventionalist, and that's done endoscopically. But some of the other areas that used to be open fetal cases are now transitioning more toward endoscopic approaches. And really, if we can do the goal of an endoscopic or any type of fetal therapy is really to prevent the sequelae. If we can intervene earlier, it can potentially prevent that baby from having the problems at birth that it would have had it followed its natural course. So it's a really exciting time in terms of fetal surgery. And then certainly in terms of treatment for the mothers, there are a variety of ways we treat the fetus through the mother. Some of those are classically fetal heart rhythms, where if the baby's, and I'll have Caroline talk, if the baby's heart rate is too fast, we treat the mother.
Does she just have to chill out?
Yes,
What's
the deal? We give mom the medication, the antiarrhythmic medication, and it goes through her bloodstream into the placenta to reach the baby. And that can be done both IV medication and orally, and actually even directly with Dr. Bevington and his colleagues, the maternal fetal medicine colleagues, to give it to them directly.
It won't. I'm totally skirting off the sidetrack here, but I find this fascinating. So if mom doesn't necessarily need to have an arrhythmia for baby to have an arrhythmia.
Yes.
But you can give mom the medication and it can help the baby and not hurt mom.
So we're treating, so we are using a healthy mom without a heart rhythm, but we're giving her antiarrhythmics for her baby.
See, this is the stuff you don't see on Grey's Anatomy because it isn't quite as fascinating to watch, but it's really interesting to hear.
And we have to monitor the baby, and again, I think that's the importance of a fetal care center and a collaborative. You know, the baby with the arrhythmia is going to be my patient. I'm determined to get that arrhythmia under control, but I have to do it through mom, and I'm in pediatrics, so I need both the adult OB doctors, but also they consult their adult cardiologists to monitor mom and make sure that the meds we're giving her are not going to affect her.
And there are other conditions where we treat the baby through the mother. Sometimes there's some infectious issues that we can treat the fetus through the mother. There are some lung issues that we try to treat the baby through the mother. So cardiology is probably the classic example, but there are increasingly those through the mother treatments.
That is so interesting.
Yeah.
All right. Well, am I missing any points? Is there anything else we need to cover before we go look at a baby's heart?
I think you got it.
Yeah. All right. Terrific.
Yeah.
Well then, if you have any questions, now's a good time to try and type them in. We're testing Jenny's camera holding skills right now because we're shifting rooms. We're going to go into, is it an ultrasound room?
Yes.
Okay.
And look at Abby's
Right next
baby.
door, and take another look at this kid. We'll see if Diana is back. Oh, Diana is here and ready for us. Terrific. Yeah. There we are. Okay. Got it. I asked earlier when we were in here, I was like, can I put my feet up on the bed? I feel so funny doing that. It's like being in a store when they tell you don't stand on things. Okay, so you want me, this is Diana, by the way. Diana is going to be taking all the pictures, and we'll remind everyone before we get started, the baby does not have, we don't know its gender at this point. So hopefully you won't catch a glimpse, but if you do, mum's the word. Okay.
We will not catch it.
We won't catch a glimpse. Okay, perfect.
Turn on the lights.
Yep.
Okay. A little bit.
And we're just going to keep it away while we get set up so we don't accidentally see the gender.
There we go. Perfect. And Dr. Lee, you were saying a little bit earlier too, there are some issues that if there's a family history or if mom has an issue, something of that nature, people might automatically be referred to you for this test.
And other reasons why a mom might be sent for a screening echocardiogram. Again, nothing is suspected to be abnormal with the heart, but just to get a closer look at the heart include identical twins, so monochorionic diamniotic pregnancies. As Barb mentioned, they're at risk, can be at risk for something called twin-to-twin transfusion syndrome, which can affect the heart, and twins are actually at a slightly increased risk for heart defects. IVF pregnancies as well, and as we talked about, maternal diabetes. So when we get those screening echoes, we tell moms that we may spend as much time just looking at the baby's heart as it seemed your OB spent looking at the entire body. We do a really detailed examination. Can I talk about your baby's heart?
Sure.
So
Yeah. Did it totally shift position since we were
Just a
looking
little
at
bit.
it? Okay.
And Dr.
This
Warner,
is
if
the
you want to go
Yes.
around towards Abby's head, I'm going to shift this way.
I just
You can go
saw
ahead.
this beautiful picture, and I just thought I had to mention. So we talked about at the 20-week ultrasound, what is your OB looking at, or what is the sonographer, the person doing the ultrasound, looking for to be reassured that the heart is probably normal in structure, and that includes 4 heart chambers. So those are shown here. Well, they were.
There we go.
And the hearts, in this case, this is the baby's spine. So this is the baby's kind of a cross-section, a transverse cross-section of the baby's body. This is the spine, and this is the baby's front chest. This is placenta, is that? Or I think that's placenta versus uterine wall. Looks like that, placenta. And the heart is actually upside down in this view. So this is the apex, or the point of the heart. 4 chambers. Look, 1, 2, 3, 4. These are the right-sided chambers, the right atrium, right ventricle, left atrium, left ventricle. So they're looking to make sure that 4 chambers are seen. These are valves in between the chambers there. So they want to look at, make sure that the 4 chambers are about the same size, that the 2 ventricles or pumping chambers are about the same size, and the 2 atria or the top chambers are about the same size. And now Diana's scanning up to look at the outflow tract. So that's the other part of that screening, part of the evaluation of the fetal heart, is to make sure that there are 2 important blood vessels leaving the baby's heart. One from the left ventricle, which is shown here, leaving the left ventricle, that's called the aorta. And then we want to make sure one's leaving the right ventricle, called the pulmonary artery, going to the baby's lung, and that they crisscross. So here's, if you can see, the pulmonary artery going this way from the right ventricle, and then the aorta is going to be crisscrossing it this way. And so that's really what the recommended evaluation of the fetal heart is at that 20-week anatomical survey. And if there's something is off in those views, that's a reason why they'd get sent here for us to look at more detail. Because we don't just stop at looking at those views with a fetal echocardiogram. We go into every little nitty-gritty, every blood vessel coming into the heart, out of the heart, looking at the speed of the blood flow in the heart, the direction of blood flow, the heart rhythm, and all sorts of detail about the heart.
And this is just like, I mean, the thing that was so crazy to me was that this is just like a standard ultrasound. There's nothing, you're not hooking leads up to anything.
Nope.
It's just a much closer look.
Yes.
With people who are trained to look specifically at the heart.
Right, yes. Yeah, who look, as I said, in much more detail than the 4 chambers and the 2 outflow tracts.
I think you brought up a good point though before, is sometimes the baby's position can make it really difficult to get the views that you need.
Yeah.
And so it could either take a long time. Do you try and wait for the baby to wake up and move around, or
move mom in all different
move all kinds of
positions.
different things?
Have
Go
mom
through
walk
gymnastics.
around. Yeah.
I actually suggest cartwheels.
Really? Yeah. Couldn't do those before I was pregnant. I can barely sit up now, so.
And sometimes you have to bring them back if
Yeah.
you can't get
Yeah.
either and if at your ultrasound your OB can't see the 4 heart chambers and the 2 outflow tracts, they may have you come back in a week or 2 to look at. But if there is a suspected problem, so if at that screening ultrasound they see that one ventricle is a lot bigger than the other, so there's a discrepancy in size, and we get that call from the OB office that they're worried about the heart, we at the Fetal Heart Center consider that sort of an emergency, in the sense that to the parents, once they hear that concern, they're really worried. They're stressed, and they just want to know what's going on. And so we really work hard to get families in, within a day or 48 hours of getting that referral. We want to be able to bring them in. If we at least offer that, if the family can get here, knowing how important it is for them to have some answers.
I have to believe that's a hand punching there because I can feel it.
It did look like that.
That's really funny. All right. And so you're looking at all of those valves, and is there anything else that you take particular care to look for?
Well, this is just one view. This is called the 4-chamber view, but we put color. Do you want to throw some color?
Yeah.
What we call color Doppler, and this shows us blood flow. So I can tell with that blue flow coming out of the left ventricle that blue flow is leaving the aorta and is going to go to the body. And that helps me see the crisscross of the great vessels again as well. Another blue line. So I know it may just look like a bunch of red and blue, but we can interpret those to see the direction of blood flow and make sure there are no abnormal connections.
All right. Terrific. Well,
Or turbulence, like a valve's not opening well. And then we do a whole bunch of other views. That's just one of many views. So this is a great view. So we can see that the baby is lying on their back here. This is the spine, and this is their chest wall, and the heart sits right behind that chest wall. Look at those ribs. Those are cool, little ribs in cross section. And this is what we call a short axis view of the heart, and looking at blood vessels and connections in different ways. So, and if we do suspect an abnormality, we want to be able to confirm it in multiple views. So this would not be done on a standard look at the heart at your regular OB office. This is more detailed. Okay. And so again, because of all the views, it can take as long as we say as a regular ultrasound.
which is about how long? I mean, 45 minutes, an hour?
It can. It depends on the baby's position. It depends on the gestation. So you are at a perfect gestation. You can see your baby's pictures are beautiful here.
Good
Look
job,
at that.
kid.
Oh, look at this candy cane shaped vessel called the aorta, which is the main blood vessel leaving the heart and going down to the body. You can follow it, and we call it a candy cane in shape, and you can see how pretty that is. And she can put some color on, and we can see that candy cane light up there. So beautiful aortic arch. So depending on baby's position,
I think it's first compliment
age,
right there.
gestational age, if mom doesn't have a lot of amniotic fluid, that can be difficult because we need amniotic fluid to help us get these pretty, what we call acoustic windows. If mom has a lot of fluid, then the baby can be moving and grooving a lot in that fluid, which can make it harder. So it does depend. It can range from Diana can do a full study in 15 minutes or less with all the different views, and sometimes it can
She's
take
just
us,
that good.
She is that
Sometimes the pressure's on.
Yeah.
At other times it can take, especially if we find an abnormality, we really want to sort it out. And if it's a very complex heart defect, it can take us over an hour of scanning time.
I think the key takeaway messages are, one, if there is a problem in the ultrasound, you can find out quickly if it really is a problem that needs more attention within,
Yes.
you said, 48 hours.
Absolutely.
And secondly, you don't always send people out of here with bad news.
No, fortunately not. I mean, the majority of our referrals are for the screening and like the twins and our IVF pregnancies, and those are often most of the time normal.
Yeah. Terrific. Thank you so much, Dr. Lee, and Dr. Warner, who's sitting here quietly evaluating the pictures. We'll get her take on it in just a second. And are we looking at anything else, or are we good to go?
We are good to go.
All right. Do we have any questions, Jenny? None at all?
No,
All
we're
right.
good.
Fabulous. Well, then I will attempt. This is my attempt at modesty here. It's all out the window now. This is a very awkward position, but I'm going to just curve right over this way. And we will be, thank you so much for joining us. We will be back next week.